Hi, everyone. My name is Dianne Davis, and I'm the Vice President of Community Wellness at Partners in Care Foundation.
Hello, everybody. Ester Sefilyan. I'm the Vice President of Network Services at Partners in Care.
And hi, Amy Adams, Director of HomeMeds at Partners in Care.
We're so happy that you could join us here today. We're going to be talking about controlling medication and social determinant of health related readmissions to hospital through HomeMeds 3.0 and care transitions. Our mission is to align social care and healthcare to address the social determinants of health and equity disparities affecting diverse, underserved, and vulnerable populations. Next slide, please. We've been doing this work since 1997. We work nationally, regionally, and in the state of California to disseminate evidence-based models of care and assure quality staffing to address social determinants of health for older adult populations with complex populations with needs for crucial in-home support. We're pioneers in conceptualizing and developing home and community-based services network, which Esther will talk a little bit more about in just a minute. And we're recognized for leading work to advance home and community-based services concepts in California and across the country. Next slide, please. So who do we serve? Well, we partner with hospitals, physician groups, health plans, community-based organizations, and government agencies to deliver services that support diverse adults and families with complex health and social service needs and their caregivers and families. Next slide, please. So what do? We create, test, adapt, and disseminate evidence-based models of care applied to care management for community living and aging well. We deliver services to improve chronic disease self-management. We identify and resolve dangerous medication errors, thus preventing falls, averting costly emergency department and hospitalizations, and preventing homelessness or nursing home through placement of in-home care coordination. We provide care management, both brief and long-term. So some services that we provide will be 60 to 90 days. Others will be from the time you start with us until the end of your life, as well as consumer empowerment through evidence-based workshops to enhance health self-management skills and behavior changes. Next slide, please. Our focus has been on innovation right from the beginning. Our CEO, June Simmons, is a rapid innovator, and we shift the emphasis from illness care to preventive care, reducing costs and improving quality of life for those with chronic conditions. We're really proud of the fact that we have just gone through, I believe, our 4th round of NCQA accreditation with a score of 98% for complex care management. Next slide, please.
As a mission-driven, community-based organization, and in really trying to meet our SDoH, our social determinants of health strategy, we know local services are the best approach to meeting individuals where they are at. And as Dianne mentioned, as a result, we created our community care hub or our network. We are the lead network entity. Our network, or the new phrase for that is called the community care hub, also called our Partners at Home, was created in July 2014 and covers the state of California and currently operates as a division of Partners in Care. We have over 30 network partners ranging from multi-purpose senior service providers, which are our 1115 waiver providers, Meals on Wheels providers, family services agencies, home care agencies, other nonprofit senior service providers, as well as private care management companies. Our network really focuses on providing short-term care management and care transition programs, community wellness programs, and we have a contact center, an engagement center, as we call it, to really help with outreach and enrollment and education of benefits. We recently expanded our services to include private duty or non-medical respite and personal care services. Our focus around this was due to Medicaid reform here in California called CalAIM, as well as the Medicare Advantage Supplemental Benefits under Chronic Care Act of 2020, which allows for purchasing and payment for such services. We are fortunate to contract, as Dianne mentioned, with health plans, health systems, hospitals, medical physician groups, and other entities as well. Our healthcare payers rely on us to help reduce healthcare costs by minimizing the need for expensive hospital, emergency department, and nursing home care. Next slide, please. As part of, we are statewide through our network, but through our variety of tools and programs, such as our engagement center, our HomeMeds program that you'll be hearing more in detail from Amy shortly, as well as our consulting and TA services, and our national work that we do. We reach across the country. Our HomeMeds is licensed in 20 states currently, and over 60 agencies providing that service. Next slide, please. As an effective care transitions, which we'll be going into details, is really a lot of times is a prime goal of healthcare organizations, but as well as patients themselves. Bouncing back to the hospital for something that might have been preventable is really no fun. Patients don't want to go back and forth into hospitals, but if done right and by combining evidence-based tools, which we'll go into detail, can save healthcare organizations lots of money, really increase patient satisfaction, which in turn impacts star quality ratings, HEDIS measures, as well as it helps reduce readmissions and in turn reducing CMS penalties as well. Some of our evidence-based tools include our HomeMeds 3.0, which is our latest version with a user-friendly interface and enhanced detection and alert system for potential medication-related problems. In addition, our other care transition tools, which again, we'll go into more detail, help close the SDoH gaps by providing social care and social services through a structured process. HomeMeds combined with these other tools are extremely powerful and effective. Next slide, please. So the Center of Medicare and Medicaid Services, CMS, conducted a national survey. And with that, actually, let me take a step back. Just recently for 2021, CMS penalized over 2,500 hospitals nationally with readmission penalties. And the look back period for these penalties go back a few years. So even though the penalties came in 2021, they're actually most likely referencing what happened in 2018, 2019, around there. So, and the biggest factors that we've seen that impact readmissions, part of this Agency for Healthcare Research and Quality did a survey, actually AHRQ did a survey that looked at 4 factors that contribute to readmissions. And those include insurance type, health conditions, timing, and patient engagement, which I'll go into detail in the next slide, please. So let's looking into that AHRQ study that was done in 2018 as to what factors impact readmissions. Top reason was health conditions, obviously, and especially in Medicare patients. Some of those top contributors there are about 5 or so major chronic conditions that impact readmission, including sepsis and pneumonia, and the ones you see on your screen. The top diagnoses also are the ones that are being looked at for Medicare penalties by Medicare. So they don't look at a lot of times all diagnoses. These would be the ones that they mainly focus on as well for penalties. Medicare and Medicaid patients are also at high risk for readmissions within 8 or more days after discharge. So insurance type. It references the population, so Medicare and Medicaid. Also timing, so lack of timely follow-up with post-discharge care for those patients after 8 days for closer to 30 days show that they develop new illnesses or chronic or complications and hence are readmitted. So the lack of follow-up physician care closer to post 8 days to 30 days show that they develop new chronic complications versus the ones who are readmitted closer to 8 days post-discharge are bouncing back to reasons why they were originally readmitted. Lastly, the study showed that lower engagement in patients with lower health and education literacy, language barriers as an example, really impact readmissions. Next slide, please. As I mentioned earlier, combining evidence-based tools such as HomeMeds with any of our care transition programs has proven to keep patients out of hospitals and increase patient satisfaction, which in turn impacts HEDIS quality measures and the Medicare star ratings. In addition, really using an alternative workforce, which was what we use, like community health workers, social workers, instead of licensed personnel, keeps the cost low and plus allows for a licensed personnel to focus on other clinical factors. So more closer to what they could focus on versus utilizing non-alternative workforce to really do the client engagement, client interface, interventions more on a social base. The alternative workforce comes from the community, and they in turn bring in experience from the community. They know the people, they speak the language, understand the culture. This allows for improved communication between patient and employee and our employees and our workers that are working with those patients, which in turn leads to trust, which will allow for stronger outcomes. Through trust building allows us for stronger outcomes.
So as Esther and Dianne had alluded, in terms of HomeMeds is really one of our tools in our toolbox to potentially help with medication errors. So as we see across the country, there's a serious adverse drug event that's happening, to millions of people each year. There's over 1 million emergency department visits each year, potentially related back to adverse drug events. The preventable adverse drug offense impact really more than over 7 million patients annually. And what we're seeing is that the causing of these potential adverse events could be falls, dizziness, confusion related to the medications that they're taking. It's very costly. We're seeing anywhere up to $528 billion in drug-related morbidity and mortality. And again, including the ER visits, the hospital and readmission, returns to the hospital and the skilled nursing facilities based on these specific adverse drug events. It's very common. So anywhere from 20 to 60% of the community dwelling elders that are living, in their homes have a medication-related problem. And this can be from a variety of different, age, functional status, health status, but we do know that it's preventable. So at least 25% with the assistance of the tools that we can provide can be preventable. Okay, next slide. So what is HomeMeds? We really like to look at it as a complement to the clinical model of care. It's really filling a gap and looking at working with a clinical care team and filling that gap with, the potential recommendations from our pharmacists. So what is HomeMeds? It's an inventory of all the medications that the patient is taking. And we have an online software, so that information is inputted. And that includes over-the-counter and prescription medications. It's looking at those potential adverse effects. So blood pressure, pulse, falls, dizziness, confusion. And what we're doing then is we're documenting that information. So how they're taking it, why they're taking it, and really painting a picture and an understanding for the pharmacist to make a recommendation after that review has been done. there are algorithms that are identified within our software that target specific potential medication-related problems. And when all that information is inputted, the pharmacist has access and can review that information, make recommendations for resolution, can provide a comprehensive report to their primary care doctor that gives an overview of their current medications, the current pharmacies and physicians that they're seeing, so they can take that to future appointments or provide that to a caregiver, so everyone is on the same page when it comes to their medications that they're taking. Next slide. So we all know that one of the top 5 drivers of mortality in those 65 and older could be medication-related problems. And with that, the major cause, again, that we're seeing is confusion, depression, falls, disability, and a loss of independence. And many of us know that if you're feeling dizzy and you don't feel good day to day, that loss of independence can really take its toll on you, or can take its toll on the caregiver that's really wanting you to feel better and keep you in your home safe. So 1/3 of seniors taking 5 or more medications will have at least one bad drug reaction each year. 2/3 of them will require medical attention. And again, that's where HomeMeds can come in. We can take a look at that so we can curb that potential reaction that we're seeing each year. Next slide. So along with the assessment, the community, the community caregiver or coach, the case manager, they will be asking a variety of different questions really pertaining to the adherence. So when we're asking about what self-reported medications that they're providing to us and over-the-counter medications, we're asking, why do you take this medication? How much do you take at one time? How often do you take it? Does it seem to work for you? And again, this is where we're really gathering the information, so we're painting a good picture for the pharmacist to make a detailed recommendation based on the self-reported information that we're gathering from the patient. Are there any side effects that they feel? It could be that dizziness, confusion, potential fall that they've had in the last week. What we really like to notate, though, is if there's anything additional to that. And then how long they've been taking the medication. We can really tell when we're looking at a prescription bottle that if they receive the prescription on a specific date and they've only taken one in the past 30 days, that's an alert. That's a flag that we're documenting and asking, maybe why are you not taking your medication daily? And it could be cost related. It could be a variety of different reasons, but we want to make sure we're getting that information to the pharmacist so they can help as much as needed. Okay, next slide. So overall, our expected results with HomeMeds is we want to see lower costs. We want to see less ER visits for our patients. We want to, hospital use due to meds, really curb that. Better health, fewer falls, improved blood pressure control, less confusion, and then just overall better care. Improved medication use. We want to empower our patients to make sure that they have the information they need to ask those questions at the next follow-up visit, and making sure that they understand why they're taking the medication so they ultimately are feeling better and healthier in their home. Okay, next slide. Okay, back to you, Esther.
As part of our care coordination services, right? And you heard from Amy on HomeMeds, we have incorporated HomeMeds Plus, which includes HomeMeds, as mentioned, plus a comprehensive evaluation and assessment with a 30-day follow-up to help with the patient implement the care plan or the service plan, and then provide referrals to the patient or work with the patient to get those services and fill in the gaps. So as part of our psychosocial assessment, which is done by non-clinical folks, so all of our interventions, our programs are really done by non-clinical folks. Our assessment focuses on evaluating patients' functional capacity, like their activities of daily living, and then coordinating access to durable medical equipment if that's what they need. Screening for depression and cognitive impairments. Assessing the home for safety, cleanliness, maintenance, observing for evidence of abuse, maybe bad odors, inadequate food, caregiving issues, flagging potential fall risk from medications, trip hazards, or poor lighting. These are just examples of the types of things that our HomeMeds Plus program really focuses on. And of course, to encourage use of advanced directives, to coach the patient or the member, the client, however you want to call it, to prepare for their physician follow-up appointments, coordinate transportation if that's something they need to get to that follow-up doctor appointment. So there's a variety of things that we are looking from a social care perspective when working with individuals in the community. Everything Amy listed with the HomeMeds program. And this is just an add-on of, let's look at social needs. Let's look at gaps. Let's look at environmental risk factors and then make sure that we're reaching back to the community to meet those needs and fill in those gaps. Next slide, please. Just as we have incorporated HomeMeds as part of our HomeMeds Plus program I just mentioned, we've also done the same with our other transitional programs. So there's we're showcasing how our HomeMeds program, coupled with other interventions, evidence-based interventions, programs, could be extremely successful and effective in keeping folks from being readmitted, saving costs for healthcare organizations, a variety of reasons why they're impactful and helpful, and ultimately really helping individuals, understanding what their needs are and just taking care of them in the community. So we've done the same with our transitions program, and really since 2013, so almost 10 years ago, we started the Community Care Transitions Program, or the CCTP demonstration project that came out of CMS under the Affordable Care Act, and Partners has been providing 3 evidence-based interventions. So you heard about the HomeMeds, coupled with Care Transitions Intervention, or CTI, plus bridge care coordination, which I'll go into details with those 2 programs. All of these interventions are, again, provided by an alternative workforce. So I'm emphasizing that it's an alternative workforce, non-medical individuals are providing these interventions. They are trained to be transitional coaches. And really the goal is to help reduce hospital from preventable readmissions and improve patient care. Next slide. So let's get into the details of the intervention. So I'm going to get into a little bit technical about these interventions, so understanding how they really work in tangent with HomeMeds. The purpose of the CTI, so what you're seeing on your screen is the Care Transitions Intervention Model, is to develop patient family skills for self-care and connecting with community resources to recover safely at home. I'm just looking at the screen here to show that the real focus is a short-term model that complements a systems care team by empowering the patient to develop self-care skills and helps them assume a more activated role in their healthcare through a whole person approach. And this is directly from the Care Transition website of how they emphasize and describe the intervention as in one sentence. But the details of it, it's really a coaching model. It's to help the patient, empower the patient and their support system, such as family, neighbors, caregivers, friends, you name it, to take charge of their health and to know what to do before it gets to a point of calling 911. It was originally developed by Dr. Eric Coleman out of the University of Colorado. Again, it's evidence-based. Now it is run by Coordinated Care Systems, CCS, They provide training opportunities throughout the year. And most of the time, the readmissions that occur during the first week post-discharge and the top two reasons for that have been around medication-related issues and lack of timely follow-up care, which we heard from the study that lack of follow-up care is a big factor in folks being readmitted. And the lack of medication issue it wasn't emphasized originally in that AHRQ study, but barriers to understanding, we saw that it was the biggest factor, like language barriers, lack of health literacy, and education are huge factors, which in turn impact a person from understanding their medications as well. So those are the things we have seen as top reasons of folks jumping back within even the first week of being discharged. So CTI focuses on those issues as well as a couple of others through its really 4 pillars: medication self-management, one of them, the personal health record, timely primary specialty care follow-up, again, emphasis on that, and then knowledge of red flags that indicate a worsening in their condition and really how to respond. It starts at the hospital. We do a hospital visit when possible. There are times when we get a referral on day of or after discharge, or when we visit the patient at bedside, and they're really not there or are unable to speak with us or getting testing done, and we're unable to see them. But when possible, during the hospital visit, we introduce the program, provide them a handout, get verbal consent to participate in the program, start building rapport, and most recently started scheduling follow-up PCP appointments with them while we're at bedside. And having this coach at the hospital allows for our staff to be really part of that care team. It's ideal for the coach to have access to the EMR, transitions to be included as part of their discharge plan, so there's no disconnect. And some things we've highlighted during the hospital visit include having a hospital care manager introduce the coach to the patient at bedside, or write out on the whiteboard with the coach name, and to help reinforce the clinical team of the coach involvement, and as well as scheduling that home visit at bedside. So some things we've really piloted around during the home visit. But upon discharge and the home visit will occur within 72 hours. We strive to do a home visit within 72 hours, but it all depends upon patient availability and then and of course, if they're not going to a short-term skilled facility for post-acute rehab or whatnot. So we will follow them once they're home. Now that the patient is home, and that's where really most of the work happen, using the care transitions coaching model, the coach will really use motivational interviewing skills and role playing to promote active participation and building their care navigation skills. The work will focus on teaching the patient to identify any red flags, signaling changes in their patient's condition in order to avoid subsequent calls to 911 and really increase the patient's capacity for self-care. That's the purpose, is to increase their capacity for self-care. These are short-term interventions, so the goal is to really leave the patient with those tools and skills to be able to manage once we're done. And again, timely physician care follow-up, I can't emphasize the importance around that, is extremely important. If patient is not able to make appointment on their own, coach will do it with them to show how it is done. And it comes down to teaching the skills. Patients really receive the system to create and use that personal health record that drives ownership of their healthcare and accountability for their recovery and sustained health. It really encourages the patient to take the PHR, that personal health record, to their doctor and review with the physician. And the coach will use also shared decision model and will engage the patient and family member and caregiver when possible. And because it's important that everybody's on the same page. Many times healthcare payers provide disease-specific handouts for coach to review and leave with patient, and we will do that. And there is a section in the PHR to really fill out how they define these red flags and symptoms of their condition, and to make sure that they review those with their doctor during their next visit. And all patients who accept this home visit by the transitional coach will also be offered that HomeMeds that you heard from Amy. That is where we've grouped this. It's where we go out in the home, we not only do the HomeMeds, we provide the coaching model as well. And then, of course, there's a series of follow-up phone calls within 30 days. And these follow-up phone calls really focus on reinforcing the patient goals, using their personal health record, identifying new red flags, concerns, and coaching the patient to complete that follow-up visit with their physician. And the transition coach will send follow-up appointment reminders and coordinate transportation again, and connect to any other social determinants and services if necessary. Next slide, please, Amy. Jip. Thank you. Now let's look at the next model. So our care transitions trio, which, we heard about HomeMeds, group with our care transitions intervention, which is done in the home. We also have another model that we've incorporated, which is our bridge model of transitional care. And the websites for each of these interventions are on the deck that could be referenced for later. And really the purpose of the bridge is to provide a person-centered social work-based interdisciplinary transitional care intervention that helps adults with complex health and social needs to safely transition from hospital back to their home and communities. It's about providing transitional support through intensive service coordination that starts in the hospital, again, just like CTI, and continues after discharge, just like CTI, to minimize the risk of complications. This social work model was developed by Rush University Medical Center in Chicago. We have used the bridge model for those who really refuse a home visit or live outside of a service area, but it is the main intervention used, one of the main interventions used during the pandemic because we couldn't go doing home visits. Again, starts at the hospital to introduce the program and determine the needs. And then after discharge, the coach conducts an evidence-based telephonic needs assessment within, again, 24 to 72 hours, just like CTI. And then once the patient is at home, the bridge model really focuses on key areas of care coordination, primary care integration, and patient and family engagement to provide a seamless transition home after hospitalization and to improve that coordination and quality of care of individuals and their families. Bridge focuses, the bridge model, which is a telephonic service coordination, is again done by an alternative workforce. The coach will work with the patient to resolve any needs, connect the patient to appropriate community-based services, as well as engage the family and caregiver in the patient's care ongoingly throughout the duration. It does arrange, again, for transportation, meals, other community services to ensure safe recovery at home. We also refer to longer-term self-management programs as appropriate and as identified during these interactions with the patient. And then there's a coach who will ensure that the patient has a timely follow-up physician appointment and a transportation to actually get to that appointment. This is a 30-day intervention. It's continued through phone calls until the patient reports that the needs are met. And again, like I mentioned, during the pandemic, this was one of our highly utilized interventions and was very effective. It was at the time that we decided to add HomeMeds as an option for our bridge program, which patients normally was done during the home visit. So we did test adding the HomeMeds program to our telephonic bridge model as well. Next slide, please. Now let's get into a little bit of results. So these are 2020 results from our health system that include multiple hospitals. We are getting the 2021 results, which is, again, preliminary, is showing similar. Our intervention group, so the folks that we have actually served in the Southern California hospital health system, had an 8.4% readmission rate among the system, so which is fantastic. On the note on the graph that in 2021, January through July at least, for the same system, we served about 1,200 patients, and of those, 109 were readmitted within 30 days. Again, similar rate, an 8.86% readmission rate for our intervention group as compared to the rest of the cohort. These are wonderful, wonderful results. And again, this is the most recent results. Next slide, please. Early on, I spoke about our CCTP program, where our care transitions interventions really in our program started back in 2013. And these are our wonderful results from those 3 interventions during the CCTP demonstration project. As you can see, across all 3 communities where partners provided these interventions, we saw a decrease in Medicare fee-for-service readmissions, and those are highlighted on the screen. 28% reduction, readmission reduction 29%, and our highest was in Kern County with 5 hospitals, which was the best in California amongst having the lowest CCTP readmission rates, and actually best in California and one of the top in the nation for our CCTP readmission rates. Next slide, please.
Thank you so much, Esther. Those are really powerful slides that you shared, and the outcomes were wonderful. On this slide, you see that in a population of 768 high-risk clients under case management, all but 14% were found to have some type of problem with their medication regimen. Whether that was to change the dosage prescribed, which was needed in 37% of this population, or because of therapeutic duplication. For instance, if someone's taking meloxicam and Aleve at the same time, that could be a very bad outcome because it can cause a gastric bleed. So these are very important issues that can easily be corrected when a provider is made aware of them. Next slide, please. In the same population, our pharmacists estimated that HomeMeds intervention helped to avoid over 300 physician visits, almost 50 hospitalizations, and 150 ER visits. With costs ranging from in the hundreds of dollars to the tens of thousands of dollars in the case of hospital readmissions, these interventions not only lowered costs significantly by avoiding these visits, but they also increased well-being and decreased suffering of the clients. A good outcome all around. Next slide, please. In another study of 250 post-acute high-risk seniors that were cared for with HomeMeds Plus, 84% accepted the home visit. Remember, we said that we met them at the bed in the hospital first to try to develop a rapport. 77% had home safety issues, so they needed grab bars, bath chairs, or an emergency response system put into their home. 12.8% had lower emergency department use compared to what would be expected. 22% had a lower rate of readmissions than it would be expected, and 53% return on investment was due to hospital cost avoidance, so not having those readmissions to the hospital. 63% of this population had some sort of medication issue that was addressed by the pharmacist, and 54% had other risk factors identified, like depression or the need for in-home support services. Next slide, please. So if we understand the key drivers of readmissions for a hospital or health plan, that's the first step towards implementing interventions necessary to reduce readmissions. The synergy that comes from using an evidence-based case management system with HomeMeds are invaluable to achieving positive results. The programs are delivered by non-clinical individuals, as Esther spoke to. We call them coaches, but they really could be VA social workers or community health workers who really understand the communities in which they work. They're both culturally and linguistically appropriate and can help with health literacy and help their clients understand how to improve their health and well-being. The coaches will intervene immediately to address anything that goes wrong post-discharge. If there's a misunderstanding in the discharge orders, there's changes to medications that need to be made or have been made, they help them understand those changes and they help to address any issues getting connected to the primary care physician, like transportation. Both HomeMeds and Care Transitions are readily available for use by the alternative workforce. I think, yep. So there's the contact information for myself, Esther, and Amy. We're happy to take any questions that you have. You can write us at these email addresses. And thanks so much for being with us today. We hope that you learned something new and that we can be of help to you. Thank you. Bye.
Bye.